A 70-year-old female has a total knee arthroplasty (TKR) done 4 years ago. She currently has periprosthetic osteolysis. It A is a well-recognized intermediate to long-term complication. B is related to generation of wear debris. C is related to biologic reaction of the metal debris with bone. D, the culprit is often particulate debris from polyethylene. E, it can be clinically asymptomatic despite bone loss. And the answer is C, is related to biologic reaction of the metal debris with bone. Okay everyone, now let's get to know more about the reason for this answer. As an introduction, periprosthetic osteolysis (PPOL) is a common complication after total knee arthroplasty (TKA). It is often caused by wear-induced particles from the implant components, polyethylene, metal debris, triggering a chronic inflammatory reaction that stimulates osteoclastic activity and suppresses the bone formation. Other reasons for periprosthetic osteolysis include low-grade infection, malrotation or loosening of the prosthesis, or an allergy to the inserted material. Massive osteolysis mostly occurs in posterior flank of the femur and along access tracts of the tibial component. It is rarely seen in the patella without a patella component in situ. Modern total knee arthroplasty have addressed the problem with wear-related osteolysis by the development of highly cross-linked thermally treated polyethylene bearings and vitamin E infusion. Osteolysis of the patella is common in total knee arthroplasty after placement of a patella component. Periprosthetic osteolysis (PPOL) in the patella without placement of patella prosthesis is rare. Hassenfeld et al., sorry if I mispronounce, described an observational study of 206 knees receiving the blocked knee system without patella resurfacing. This is cohort. 25 knees, around 12%, develop osteolytic lesions of the articulating part of the knee without any clear explanation given by the authors. Risk of periprosthetic osteolysis in specific patterns of porous coating in uncemented implants, in modular components versus monoblock, flat inserts versus deep dish, presence of screw fixation, lower sterilization dose of inserts, the shaft edge of the insert. This first picture shows the nodular component of total knee arthroplasty, the tibial tray, and the second picture illustrates the femoral modular component. further risk of periprosthetic osteolysis, cruciate retaining implants, biomechanical changes, the posterior femoral condylar offset and joint line replacement, patient age, and lastly, higher in male patient. The formation of debris particles, especially from polyethylene, affects the long-term durability of the implant, causing mechanical failure. Polyethylene debris incites a chemical and cellular inflammatory reaction, resulting in bone resorption and osteolysis. The extent of osteolysis depends on the volume, size, and shape of polyethylene debris. The main causative factor leading to osteolysis is small particulate debris, which stimulate an inflammatory foreign body cellular response, resulting in bone resorption. In contrast, the large polyethylene particles associated with delamination of the polyethylene and fatigue wear do not elicit the same cellular response. Wear is a motion-driven abrasive or adhesive process, and delamination is a stress-driven mechanical process. In total knee arthroplasty, polyethylene wear occurs from a combination of rolling, sliding, and rotational motion on the bearing surfaces. Polyethylene damage in total knee arthroplasty occurs on the articular surface as abrasive wear due to the sliding motion of the femoral component on the tibia. Pitting, delamination, and flaking are caused by cyclic loading and oxidation of the polyethylene. Tibial post wear in posterior stabilized designs can be seen as delamination, deformation, and fracture. Tibial backside wear occurs as abrasive wear, pitting, flaking, or delamination. This picture illustrates an example of abrasive wear. On the right-hand picture, there is a pitting, scratches, and machining marks. More explanation. There are numerous causes of osteolysis, including the component design, quality of the polyethylene, manufacturing process, and sterilization technique. The impact of the component design depends on the conformity of the femoral component on the tibial polyethylene articular surface and the resultant contact stress. Articular surface designs with small contact areas between the femoral and tibial components distribute forces over a limited area and increase the stress on the tibial polyethylene. Regarding modular tibial components, this resulted in new modes of failure in total knee arthroplasty. Modular tibial base plates with screw holes cause polyethylene backside damage, and they create a portal for polyethylene debris to enter the tibia. In cementless design with holes in the base plate, tibial fixation screws or discontinuous porous surface that serve as a conduit for debris which lead to osteolysis. In cemented designs, invasion of the polyethylene debris occur through voids in the cement mantle. In the tibial polyethylene locking mechanism, depending on the security of the locking mechanism, micromotion occurs between the tibial polyethylene and the base plate, leading to backside wear of the tibial polyethylene component. The surface finish of the tibial base plate also impacts the extent of backside wear. Manufacturers have attempted to reduce the backside wear by improving the locking mechanism, improving the mobile bearing designs, and reintroducing monoblock tibial components. Regarding polyethylene, the tibial polyethylene component is usually manufactured by either a net-shaped molded technique or is machined from bar stock. Machining of the polyethylene may predispose polyethylene to surface and subsurface irregularities, which can lead to delamination and failure. In compression molded polyethylene, it has less wear than components machined from extruded bar stock. Method of sterilization impacts the mechanical properties and the durability of the tibial polyethylene components. Polyethylene sterilized by gamma irradiation in air produces free radicals with oxidation of the polyethylene, which leads to premature mechanical failure, generation of polyethylene debris, and ultimately osteolysis. Current implants are sterilized in either ethylene oxide gas or gamma irradiation in an inert oxygen-free environment. In highly cross-linked polyethylene, it created a stronger three-dimensional structure of the polyethylene, resulting in improved wear-resistant polyethylene with less oxidation and a diminution of residual free radicals. Additional developments including oxygen quenching additive such as vitamin E. Osteolysis is a progressive condition that should be diagnosed early, and the treatment should be initiated before complication as periprosthetic fracture or substantial loss that renders the revision arthroplasty more difficult and complicated. Most patients who present with early osteolysis are asymptomatic, and osteolysis is an incidental radiographic finding. More regarding radiographic findings, osteolytic lesions are typically radiolucent lesions adjacent to the component. They may have sclerotic border or thinning of the adjacent cortex. The implant may obscure the osteolysis, especially femoral osteolysis with posterior stabilized implants that have an intercondylar box. This lateral radiograph of knee shows osteolysis present especially at the femoral component, post-total knee arthroplasty. Oblique radiograph may help to visualize osteolysis in the posterior aspect of the femoral condyles, especially with a posterior stabilized prosthesis. Radiographs tend to underestimate the extent of the osteolysis. Multi-detected CT is a useful imaging study to determine the extent of all lesions. MRI with metal suppression can be used to evaluate the degree of osteolysis. Yay! We have reached to the end of this video. See you in the next one. Take care and bye.